Attention deficit hyperactivity disorder is a mental health disorder with 3 core symptoms: hyperactivity, impulsivity, and inattention. In order for a child to be diagnosed with ADHD, he or she must exhibit symptoms in at least 2 locations. They must be present for at least 6 months, and they must be present before the age of 12. Today, 1 in 5 children in the United States is diagnosed with a mental health disorder, and the majority of these are for ADHD. According to the Centers for Disease Control, 6.4 million children are diagnosed with ADHD and have been diagnosed since 2011. Sadly, this number continues to increase. That number is nearly 11% of children in the United States. Recently, a parent came to me in distress. My child, she said, is throwing things, hitting, kicking, biting. He's acting terrible. The medication you prescribed him doesn't work. I need you to fix this. Can we please increase the dose? I hear this same story with a different cast nearly every 15 minutes during a day's work in the pediatric neurology practice. I am the mother of 2, an Army veteran and a pediatric nurse practitioner. Yet one of the biggest battles I face on a daily basis is trying to help parents understand that stimulant medication is not the only treatment for ADHD. The majority of children with ADHD are placed on a stimulant medication such as Adderall or methylphenidate. Sadly, there are very few studies on the long-term effects of this medication on children, yet they're prescribed to children in alarming doses and amounts. It is not uncommon for a child to try up to 5 different stimulant medications in varying doses to see if they can achieve behavioral control, and oftentimes that control is never achieved. The side effect panel for stimulant medications is actually pretty tough. Kids that take stimulants often lose their appetite, they lose weight, they have trouble sleeping, they pick their skin. But yet we still prescribe them. One of the common themes I see in practice for kids with ADHD is that these kids are brilliant. They're quite remarkable. They're artistic, they're talented, but sadly, they are also poor problem solvers. They lack self-control, they're quite impulsive, and they're known to be angry. That's just my ADHD. These children often blame their symptoms on their diagnoses. So the way I practice medicine changed the day I met Isaiah. He was 8. Isaiah's mother described him as combative and argumentative. He was quite rude. During his exam, Isaiah punched me. He had recently been let go by his psychiatrist. This child was fired by his own psychiatrist for failure to conform. Again, he was 8. Isaiah had several diagnostic tests completed. All of them were in the normal range. His MRI, his sleep-deprived EEG. I gave him a Wessler IQ test, and he scored in the above-average range. I couldn't understand what was going on with this child. Isaiah weighed in that day at 27 kilograms, and he was on an impressive 81 milligrams of stimulant medication. That is nearly 3 times the standard dose for a child that weight. I had no idea what I was going to do for Isaiah that appointment, but I knew one thing for sure. I was not going to prescribe the amount of stimulant medication this child needed to obtain control. Anyone who knows a nurse knows that nurses love to provide patients with education. We provide education oftentimes more than we want to give medication. And so anyone who practices medicine understands the challenges associated with a 15-minute appointment. I knew that in my 15-minute appointment, I had to change this child's mind about his ability to control his behavior and his mother's mind about stimulant medication being the only method she could use to treat this child. And so what did I do? I started to draw. I drew what I call a tale of 2 ladders, one big and one small. A small ladder is on the left and the large to the right. I drew a speech bubble above each ladder as this child waited for me to complete his appointment. Next, I drew a large light bulb in the middle, hoping that at some point in time, I would come up with a bright idea. I drew a legacy box in the lower corner of the ladder. The next thing I did after I finished my artwork, I engaged this pediatric patient. I asked Isaiah to name for me a behavior that manifested in his life that was difficult for him, to which he named tantrums. Next, I asked Isaiah, please tell me 3 things that happen when you have a tantrum. Isaiah told me biting, hitting, and throwing things. Imagine sitting across from a child, an 8-year-old child who was still biting people. I jokingly said to Isaiah, are you a dog? He looked at me and started to giggle. As we wrote these behaviors on the paper, Isaiah's expression started to change. He looked at the paper and he grew very sad. I tried to change the course of the conversation as I pointed him to the other side of the ladder, because Isaiah showed me at that moment he had self-awareness. We started to write on the other side of the paper, and I asked Isaiah, please tell me the opposite of poor behavior choices, to which he replied, that's easy. That would be good behavior choices. Next, I engaged my patient and challenged him to change. I asked Isaiah to list for me behaviors he thought he was capable of achieving and to write them on the ladder, and he started to write. His entire countenance changed. The next thing I said to Isaiah was that change begins with you. You cannot change what you do not confront. Isaiah looked happy. Next, we started to fill out that light bulb in the middle of the paper. And here, I helped Isaiah outline strategies, coping strategies that he could use when he was having trouble with his behavior. We used what I call the personal stop command, that he could tell himself to stop a poor behavior. I taught him deep breathing, and then I taught him to use positive self-talk. Lastly, we completed what I call a legacy challenge. I asked Isaiah what he wanted to be known for from that day forward, and he said, terrific kid. I want to win terrific kid in school. I saw Isaiah 3 months later, and I have never seen a child so happy to see me. His grades changed from D's and F's to straight A's. He climbed in my lap and hugged me. And he told me that he was no longer getting in trouble. This child was making friends. His anxiety and his depression lifted by simply refusing to increase his dose. At the end of that appointment, Isaiah's mother looked at me and said, I think I'm ready to decrease the dose. Mind you, I never put him on the 81. I put him on just 10 milligrams of methylphenidate. And we went down to a standard 5, which is a dose that I typically start a 5-year-old child. And so I would like to leave you with 2 wisdom keys. Key number 1, prescription medication is not the only intervention that works. And wisdom key number 2, empowering children brings about positive change. Oftentimes, the simplest solution is the most powerful. Thank you.